Sean, you want to start?
Yeah, I'm good.
All right, welcome everyone. This is our first and hopefully one of many multi-chapter events virtual in this virtual world of ours. This is public health panel, and it should be very interesting and exciting. We're going to have one of our panelists probably join us a little bit late, and then maybe have to drop off. But I'm going to hand this over to Dr. Sean Gibbs to make the introductions.
Hello all, it's nice to be joining you here today. I believe we're going to be working on muting a loud typer there. Thank you very much. It's wonderful to be joining you all today. We've got a lovely panel discussion set for today. And our first panelist that I'll go ahead and introduce is Dr. Peter Hotez. Dr. Hotez is Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine, where he is also the Director of the Texas Children's Center for Vaccine Development and Texas Children's Hospital Endowed Chair of Tropical Pediatrics. He's also University Professor at Baylor University, Fellow in Disease and Poverty at the James A. Baker III Institute for Public Policy, Senior Fellow at the Scowcroft Institute of International Affairs at Texas A&M University, Faculty Fellow at the Hagler Institute for Advanced Studies at Texas A&M University, and Health Policy Scholar in the Baylor Center for Medical Ethics and Health Policy. Dr. Hotez is an internationally recognized physician scientist in neglected tropical diseases and vaccine development. Most recently, as both a vaccine scientist and an autism parent, he has led national efforts to defend vaccines and to serve as an ardent champion of vaccines going up against growing national anti-vax threat. In 2019, he received the Award for Leadership and Advocacy for Vaccines from the American Society of Tropical Medicine and Hygiene. Our next panelist is Dr. Umair Shah. In 2013, Dr. Shah was appointed Executive Director and Local Health Authority for Harrison County Public Health. The nationally recognized and accredited $100 million agency comprises 700 public health professionals, serving the nation's third largest county with 4.7 million people. Dr. Shah has enjoyed a distinguished career as an emergency department physician at Houston's well-respected Michael DeBakey VA Medical Center. His journey in public health began as Chief Medical Officer of Galveston County Health District before joining Harris County Public Health to oversee its clinical health systems and infectious disease portfolio. Under his leadership, Harrison County Public Health has won numerous awards, including recognition as Local Health Department of the Year by the National Association of County and City Health Officials in 2016 for its work in innovation, engagement, and health equity. Sought for his practical insights, Dr. Shah has presented in both the Texas legislature and on Capitol Hill and sits on numerous national boards and advisory groups, including with the National Academies of Science and Engineering and Medicine, the U.S. Centers for Disease and Control and Prevention, the Network for Public Health Law, Trust for America's Health, and the Texas Department of Health Services. He previously served as president of the National Association of County and City Health Officials and its Texas affiliate, representing the nearly 3,000 local health departments across the U.S. He remains active in clinical activities across Texas and Texas medical center institutions. Joining us from California, we have with us Dr. David Solilis. Dr. Solilis is the Director of COVID-19 Response Team Program in the Public Health Susan and Henry Samuel College of Health Sciences for the University of California, Irvine. Mr. Solilis has 33 years of experience in public health. Currently, he serves as the COVID-19 Response Director. In this role, he provides leadership in COVID-19 response planning, as well as designing and operationalizing COVID-19 campus-based contact tracing. Has previously served in a number of roles with the Orange County Health Care Agency, including Deputy Agency Director, Director of Public Health Services, Public Health Chief of Operations, and Division Manager for Disease Control and Epidemiology. In these roles, he's led public health programs serving a population of more than 3 million. Prior to joining, Mr. Solis had previous senior public health positions, including appointment by Governor Gray Davis as Chief Deputy Director of the California Department of Health Services and Prevention Health Bureau Manager and AIDS Public Program Manager for the City of Long Beach. His career as an HIV/AIDS health educator for UCI as well. He holds a master's degree in public health from the University of California, Los Angeles, and an undergraduate degree from the University of California, Irvine. Our final panelist.
Mute your. Can't you just mute it?
Can the moderator make sure everyone's muted for us? All right. Thank you, moderator. Mr. Jorge Orozco is currently the CEO at Los Angeles County and USC Medical Center, one of the largest and most complex hospitals in the United States, dedicated to providing world-class care for all. Prior to his appointment in 2018, he led the Rancho Los Amigos National Rehabilitation Center as the Chief Executive Officer since 2007. Mr. Orozco began his career as a physical therapist in 1988 and continues to practice at the Los Angeles County USC as a physical therapist. Mr. Orozco earned his Master of Science degree in Healthcare Management from California State University, Los Angeles, a physical therapy degree from the University of California at San Francisco, and a Bachelor of Arts in Biology from the University of California at Santa Cruz. So that's our distinguished panel we have for us today. And we have a number of core questions for them that we'll be hopping into. So with no further ado, I'll hop in with our first question, and I'll just throw it out to the panel and just ask the panel, what have been the greatest challenges in the fight against coronavirus that you've experienced at your institutions?
Dr. Gibbs, hi, this is Umair Shah. Let me just jump in, and I know the colleagues on the panel, I'm sure will have additional thoughts. And first of all, thank you for, for having me be a part of this panel, and it's great to see everybody, and I'm really looking forward to this discussion. We're a public health department, right? A local public health department. Our job is not just the academic piece of it, but really in practice. It's applied. It's the work that we do to protect communities, and I would say that my biggest challenge as a leader of health department for the third largest county in the U.S. is really been the fact that this has not been a health and medical response by and large in this country. It has been a political football. It's been politicized in a way that has really made it very hard for us on the front lines to do our job. And frankly, anytime you have inconsistent messaging or policies that are at, I don't care what level of government, federal, state, local, it actually causes an incredible amount of confusion and complacency at the individual community member level. And then people just simply take chances with their health. And they say, let me just go out, let me risk it. And when you see that happening, then it makes our job ever more difficult at the local public health level. So yes, there's all the stuff we talk all about, funding and financing and capacity and prevention and all the things that I've said for a decade plus, that we are the offensive line of the football team, and we are really behind the scenes when we do our job. It's largely invisible. But I think the biggest problem is we have just had a very politicized fight against COVID in this country, at least.
And this is David. I certainly would echo Dr. Shah's assessment. I spent the first 5 months of the pandemic as the public health director in Orange County, California. I think we're the 6th largest county in the country. And we had the distinction of having, I think, the second case in the country back on January 25th when we reported out. And I would agree. I think really as the pandemic evolved, the political machinations and arguments won the day over public health science, I think, and created challenges for all of us in the public health profession to be able to effectively respond with appropriate public health mitigation measures. I don't think it's any secret to anybody the stories of the number of public health officers and public health directors who've either retired, resigned, or been fired throughout the course of the pandemic as a result of trying to implement effective, tried and true public health policies. So I think truly has been one of the key challenges for us in trying to effectively respond. And I would agree too. I think we have, from the public health perspective, been suffering from decades of neglect in investment in our public health infrastructures. And under the weight of a global pandemic, we're seeing the result of that lack of investment over time in our workforce, in our data systems, and our ability to be able to rapidly and effectively respond.
So, Jorge, would you care to add in? Oh, Jorge, I think you may still be on mute.
Okay, how's that?
Perfect. Thank you, sir.
Right. So, first off, it really is an honor to be here to represent a hospital perspective during this pandemic. You know, we saw this wave coming. We saw what was happening in China and Italy, and before it hit California, and
Jorge, apologies. I'm sure you're saying something brilliant, but your mute's clicked on again.
Okay. Can you hear me now?
Perfect. Yes.
Yeah, I'm on the phone. I'm not sure who's centrally controlling the mute stuff, but so I don't know what you heard of this, but just saying that our planning efforts were a little misguided in that we were putting up tents, we were identifying alternative locations for ICUs, and we were gathering equipment. And I think in retrospect, our biggest challenge was the people, our employees, and the impact and the emotional and psychological impact of this pandemic. The challenge of keeping a workforce safe and engaged in the hospital was probably our largest challenge. We had a significant number of call-offs. People were afraid. People are afraid because the message around keeping them safe was evolving. You know, the science behind how this virus was transmitted was evolving. So I would really say that was our biggest challenge here at the hospital.
Excellent. Would any other panelists care to weigh in on that question, which was what have been your greatest challenges in the fight against the coronavirus?
I mean, I'm happy to add just a few more thoughts from my perspective, having served in that local health department role in the initial months of the pandemic. I think, you know, we were struggling with, you know, all, you know, including kind of these big picture issues. I think it's all of the challenges that we're all continuing to suffer with today. The challenges, and Jorge, I think, sort of addressed this, not only the evolving information, but the misinformation and the disinformation that is spread around this pandemic, making it difficult to get communities to be all in terms of protective behaviors that we all need to be all in on in order to be successful. That, I think, has been incredibly challenging. I think, it really sort of goes without saying, but the lack of testing capacity in the early months of this pandemic really tied our arms in public health and our hands behind our backs to be able to effectively respond when some of those initial cases were occurring and those clusters were occurring. And we just did not have the ability and the capability to be able to test in the kind of effective way that we knew we needed to for a public health response. And, I think, again, repurposing our workforce in sort of rapid succession to be all in on pandemic response, right? At the expense of many of our other public health programs and services. So we I think will see decades of fallout from COVID-19 in terms of its impact on other public health issues, whether it's maternal and child health issues or STDs or obesity, et cetera. It's just we have been all in on COVID at the expense of many of our other public health priorities. So I think those, again, have been some of the kind of the real world challenges. And then I think the fatigue of our staff, right? The fatigue of all of us as a country in responding to COVID-19, but then the fatigue of those that are really, in the frontline responding roles in our health departments, I think is something we're all having to contend with at this point in time too.
David, a wonderful point there, and it dovetails very nicely into our next question. So I wonder if I could go to Jorge here for this one. And it's what problems did the health delivery system face in your communities?
I do think that we probably faced all the problems that everyone else faced. I think the supply chain competition was global, and the ability to access appropriate PPE was not a centralized, coordinated effort. It was pretty much every organization for themselves, and our organization really faced that. And we were following leads, and many of those leads turned out to be not fruitful. So I think, PPE, access to testing had a huge impact on how we deliver care. The impact of having a patient admitted because of an orthopedic trauma into our wards, and then 3 days later starts developing respiratory symptoms, and then gets tested, and then we wait 3 days to get the test back because we don't have the testing capabilities in-house, and then the test is positive. And the impact and the shock wave that sends across all of our staff, and then the number of people that have to be quarantined after that. I think, those are the real problems that we were facing initially under this pandemic, and our whole system faced the same issues.
Thank you for that. I wonder if we could go to Umair next, and then David with that same question there, which is what problems did the health delivery system face in your communities?
Here.
So can you hear me okay?
Yes.
Very well, thank you.
Okay. Yeah, I just, what Jorge just said, and, and David right before that, I think really highlights what some of the challenges that we have had. And, I do think that it's this intersection of public health and healthcare. I mean, this is a primary public health crisis with secondary impact everywhere else, including in the healthcare system. And if we had dealt with this in a public health way, I think it would have helped our healthcare system be markedly, not necessarily would have taken away everything, but I do think it would have really helped appreciate all the elements that our healthcare system unfortunately had to go through. And in our community, Harris County and Houston, what we really focused on was I looked at it maybe a few phases. The first phase was really trying to underscore what was happening across the globe, and then a frenzy of activity, as David said, really early on when communities across the country were trying to figure out their first set of cases, and then right after that there was this sort of slowdown period where it was stay home, work safe, and things were closed down, and then there was this reopening phase, and then we've gone through a couple of phases after that. During that period of time where we, as everybody talked about flattening the curve, I do think we successfully in our community flattened the curve. We helped buy time for the healthcare community, which was to learn from others across the globe or across the country. So, you don't put your patients on their back, for example, if you may need to put them on their stomach. You don't go to the ventilator initially. IV steroids or IV remdesivir or what have you. Just all sorts of real important lessons that we were learning from across the globe or across the country were really about buying time for our community. But in June, July, when our community, especially because our governor and the state, what I thought went too fast and too quick to reopen, what that did was it actually overwhelmed our system. And so what happened is that since we weren't seeing New York City, we weren't seeing Seattle, King County, we weren't seeing other images from across the country happening in our community, then people decided, what, we'll reopen, we won't wear masks. And so all of a sudden you had this incredible increase. And then you started to see this real challenge around data sharing and communication and collaboration. How do you get EMS to take patients to which hospital, and how do you make sure that the community understands what's happening? We are fortunate to have Texas Medical Center here, and our TMC partners did a fantastic job, but there were hiccups around data and really visualizing that. In fact, you go to the TMC website, you can see the data points that have been out there for months and months, and also our RAC, our Regional Advisory Council with CETRAC here, that really allowed for a coordinated piece of what was happening between the healthcare system, public health, and in between EMS. But ultimately, to me, it was really about the concern and confusion in the community. When people started to see hospitals not so overwhelmed, they felt, I don't need to worry about all the things I need to do to protect myself. But then guess what? That's when you started to see the overwhelming nature. And then when you saw things get really bad, then people said, oh my gosh, I better stay home, better wear my mask. And so it's just this ping pong effect that I think has been the public health healthcare intersection throughout the last several months.
I think the ping pong effect is a wonderful description of what we've all been feeling. David, would you like to weigh in with some thoughts?
Sure, and I certainly concur with all of the comments that have been made. And I know Jorge and I are sitting here in Southern California, and we have within the same media market probably half of the state's population across the 4 or 5 counties here in Southern California that share that media market. And so messaging became a challenge, and I think for us, looking across borders about what each of our jurisdictions were doing and how that planning was going. And I think we all experienced, particularly around the surge planning, some real challenges in our abilities to effectively do surge planning. I think, one of the things I think we're really good about here, and I think, many communities is our emergency response planning, right? And our emergency response planning relies on the ability to be able to surge, the ability to be able to look to mutual aid to help out when you're in crisis. But most of the time, and much of our planning around emergency response and surge has been to deal with disasters or crises that are geographically limited, right? And I think this, at least for me in my career, was one of the first times where, our entire system was saturated across the country. So the traditional models of mutual aid and support of sharing, supplies from the Strategic National Stockpile or sharing supplies between communities became very, very difficult. Our ability to try and really effectively plan for surge across regions was, tested to its limits. And I think, over time, challenged by the fact that we were not very successful at being able to effectively, model what was going on. I think we all saw New York, right? And we were all really nervous. We saw what was going on in the early days up in Washington, and we were all trying to plan for something that was very hard to predict, and in many communities didn't materialize the way we thought it would. In part, I think, as Dr. Shah said, to some of the good public health interventions that did take place to help flatten that curve. But also, I think our modeling was just off. We were challenged because we didn't have good models in place to be able to help do that planning. And then we had every community trying to do the planning based on a system that relied on mutual aid when everybody was trying to hold on to resource because they were afraid to let go for their communities. And I think that really, those were just struggling times, trying to sort through that. The competition that Jorge talked about for PPE, for ventilators, for having enough, having more than enough, in many cases, as was the expectation oftentimes from elected leadership. So I think that created really some unprecedented stress and strain on not only the healthcare system, but the public health system, and where that intersect is between those two systems.
Wonderful comments there. It reminds me of a documentary I watched a number of years ago surrounding the near meltdown at 3 Mile Island. And they were talking about the emergency response plan for the communities surrounding it on either side of the river. And one community's plan was to go to the other community, and the other community was to go to the other community. So we kind of found ourselves in that situation on a national level. So what about the rest of the panelists? Anyone like to have a closing thought on this question before we move to the next question? All right. The other thing that I would like to mention is I forgot at the top of the session to introduce myself. Apologies. My name is Sean Gibbs, and I'm Dean of the School of Public Health here at Texas A&M University. Thank you for tolerating me this evening, as I'll be your moderator for the remainder of the session. And so apologies for not mentioning that at the top of the hour. So with that, we'll move on to our third question. And our third question here is, there's been a lot of focus and coverage on healthcare delivery systems. There's been a lot of news coverage and a lot of news coverage focused on hospital inpatient response to COVID. But do you see the pandemic as more a healthcare delivery system issue or a public health issue? And can you expand on your perspectives? And I wonder if we couldn't go Jorge, David, and then Umair at this point.
Well, that's an easy one for me. Even though I'm in a hospital, it clearly is a public health issue. And like Umair shared, we are sort of on the secondary lines of the impact of our public health behaviors. It's been very interesting being in the hospital during this pandemic, in that as the public health orders have come out to close indoor dining, to require masks, to hospitals are actually exempt from those. And so we have had to keep our operations going and keep our cafeteria open and keep our food services going during this time, with a lot of mixed messages that our employees and our community are hearing. So that's been quite a challenge. But I really defer this question to our public health experts, because that's what this is about.
And as we're moving on to Umar and then David, I'd like to remind and ask everyone to please make sure you mute your microphones. So Umair?
Yeah, I think Jorge just said, I said this in the previous question, and I'll just reiterate. The reason that I feel that it's a public health crisis with secondary impact in the healthcare system is that ultimately pandemics and the real prevention of, the surveillance for, the mitigation of and response to is really public health in nature. This is a zoonotic disease, right? It's a novel virus. It made a jump from animals to humans. And in fact, not putting a plug in, but we have a One Health conference tomorrow afternoon with a number of folks that are going to be on. And we have over 1,000 people that are registered. So please join me and go to our website. That was a shameless plug. I so apologize for that, John. But in all seriousness, is that this is really what we in public health have been planning for. And David said this just so eloquently. We have planned for this for years and years and years, and it's somehow that it was taken away from public health, because I think at some point people maybe a lot of folks weren't paying attention to what public health authorities, what that really means, public health powers, legal activities. You have people like me, a health officer, a health authority. What does an authority really mean? I don't think people really put that into play. And all of a sudden, you've got people you've never even heard of. Who's the Shaw guy who's able to enact something? What is the county elected official or the city elected? How can they do these things? I didn't ask. And I think that there has been it's almost that we have to re-educate communities about how government really works in the midst of in an emergency. And David and Jorge have just hit it on the nail, that this is really an overwhelming response that hits all elements of society. That transformation really starts first and foremost with public health. And unfortunately, if over the decades you underinvest in it, you undervalue it, you underappreciate it, or you just don't pay attention to it, then you have those health officers or health authorities or legal powers that nobody was paying attention to for a century. Or maybe we did kind of 10 years ago during 2009, 2010 with H1N1, but it didn't really have to happen. Bam. And here we are. And so I do think that the secondary impact is obviously societal, but it's public health. Unfortunately, I think a lot of folks didn't understand it and didn't feel comfortable with what that meant. And now we've got a whole host of other issues that we have to deal with in trying to explain what that really means.
Thank you for your insights there. On to, I believe, our next panelist, David.
Sure. Yeah, and I would just echo again what Dr. Shah and what Jorge have been saying. I mean, clearly, a public health response is sort of the lead response here. Our healthcare communities in any public health response, our hospitals, our healthcare delivery systems are critical partners in that. If we're successful in the public health response, it alleviates the impact on the healthcare delivery system, right? We know what to do. This is, at this point in this pandemic, it is not a secret, right? We know that physical distancing works. We know that face coverings and masking works. We know that surveillance testing and efficient contact tracing work. We just need to be all in and all behind that. And if we are, it's going to dramatically reduce the number of cases that we see and the number of people that end up in our hospitals needing the great quality care that our healthcare system can provide when somebody finds themselves there. But I feel like we've lost the ability to be all in on all of those measures in this country at this point in time. And, the political rhetoric that is occurring as part of the election clearly has not helped that, whatever your political persuasion is. It just has not helped our ability to be able to speak with one voice. I think the discrediting of health officials is been a tremendous detriment to our ability, again, to effectively respond. Our public health officers, our healthcare leaders, our healthcare experts, our hospital experts have somehow become suspect in the conversation now, as opposed to positioned as the leaders and the voice of the response and of the appropriate and effective response. And somehow we've got to find our way back to that. so that this public health response that ship can be righted, and we can get our community back to where it needs to be. We can't treat our way out of this, right? It is a public health response first and foremost, and it gets to the core of people's behaviors and getting communities, individuals and communities, to be all in on the response. And that is a traditional public health philosophy and approach, regardless of the issue that you're talking about.
Now, David, I think you're peeking at my notes here, because you've moved on to my next question. And my next question was going to be, what have been the most significant issues with which public health in your community has had to deal? So since David really started really getting into that, I wonder if we couldn't go to Jorge and then Umair and get their perspectives on that.
I don't want to speak for public health officials and what has been their most significant issue. I do want to echo the challenges in the messaging and the ability to align community response. I think that has been such a huge challenge, and we've contributed to that. We're part of that process in that, we've been sending messages to our employees, sending messages out to our community, and then a week or 2 weeks later, that message changes in terms of what the response is. So I think that has been the biggest challenge from my perspective.
Dr. Shaw, your thoughts?
Yeah. In addition to what you just heard from both my colleagues here, who I think they're spot on. I would just add the other piece of this is that lack of strategy, lack of leadership at that national level has meant that you've had essentially 50 states that have been trying to figure it out on their own. You've, by the way, also competing for precious resources. And you've also have, as the president of NACCHO, it doesn't completely apply here, but it was representing 3,000 local health departments. So, I know we have markedly more communities than that, but at least 3,000 communities across the country that are also trying to figure it out on their own. And I really believe that leadership and that strategy void from a national perspective has had talk about trickle down. It has had a trickle down effect to all of us. And, it starts first and foremost with the underpinnings of CDC and how CDC was marginalized. And you don't know what, I think David and Jorge have said this very, very appropriately. It is election season. We don't really know how much is really related to what we're seeing, what we're not seeing. And we know there's a lot of politicizing right now as well. But if you read the media reports of what appears to have happened with the CDC, especially, and I went very, very hard at it on Twitter with, and my team was like, wait, are you sure you want to do that? I was like, it's the right thing, is when CDC said, you know what, if you're asymptomatic, you've been exposed to somebody with COVID, you may not need to get tested. And I was like, what? That's like months of all of us, healthcare and public health, saying the absolute opposite, science and evidence saying the absolute opposite. And then CDC made that pronouncement. And I think it's that real lack of, and fill in the blank, that has really made it difficult for all of us. And then, David said it absolutely correctly, that, this is a system-wide issue. We call this crisis standards of care, crisis care, this catastrophic disaster response. And it really is, it's not like a hurricane where it's in one part of the country, or a storm somewhere, or a wildfire somewhere where you can bring resources from mutual aid from elsewhere. This is all of us, and we're all, and unfortunately, that means that we've also had to compete for resources. So when we say we need test kits, and then you hear that, another community is getting those test kits, or we need PPE and another state is getting those, or vice versa, I think it's a terrible way to really run a public health response.
Thank you, gentlemen, for your insights. Being with two chapters, one from Texas, one from California, we have a very diverse range of communities, going from some of the wealthiest communities in the country to some of the most resource-limited communities in the country. So given that it's pretty widely accepted at this point that the pandemic has had the hardest impact on those communities that are most resource-limited and on individuals of color, how have health inequities played into pandemic response? And I wonder if we couldn't go to David, and then I see Dr. Hotez has joined us. So I wonder if we could go from David to then Dr. Hotez.
Thanks. In Orange County, we have some of the richest communities in the country, and we have some of the poorest and hardest places to live as well within the span of our county. And I think our challenge always has been how you deliver an appropriate public health response to such a diverse community, both economically, racially, ethnically. Is a challenge. And I think, we prided ourselves on having good linkages and connections with our community partners across all communities. But I think we saw that clearly there was more work there to be done. The relationships with our communities needed to be strengthened. And I think, we saw very clearly as COVID evolved, the impacts on our poorer communities, the impacts on our populations where housing was more crowded and more dense, where households were larger. We're seeing that continue to play out today. And I think, the issues that are always there are exaggerated in a pandemic, right? So issues around coverage, issues around access if you do have coverage, whether that's to healthcare or to testing or to appropriate prevention messages and the support to be able to do those appropriate prevention messages, to implement those in your life can be a challenge, depending on your, where you live, what your economic status is. And we are in the middle of it, right? We have broken systems that still need to be fixed and that are trying to respond and deal with the equity issues that exist in the country in the healthcare and wellness space. And I think it's going to continue to be a challenge for our communities. I think folks are trying to step up on the public health side and on the healthcare delivery side to meet that need. But again, we're fighting against decades of issues and challenges that have been systemic in our communities for generations. And the pandemic brings out the best and the worst, right? It brings out the best in people. It exposes all of the warts and all of the challenges in our systems to be able to effectively respond. And I think, points to the need to keep ourselves kind of laser focused on where we need to go.
Thank you very much. Dr. Hotez, I wonder if we couldn't ask you the same question. And how do you feel that health inequities played into the pandemic response?
Well, thanks so much. And I apologize for joining late. Just a number of urgencies came up. I think one of the things that really impressed me, and I see Dr. Shah is on, Umair is on, and we've spoken about this a number of times. Every day the Houston Health Department lists the deaths from COVID-19, the individuals who perished the day before from the virus. And, it's seeing the same pattern every day. It does not provide the names, but it provides the age, race, and ethnicity. And every day it was the same thing. It would say Hispanic, 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 Black, Black, Hispanic, Hispanic. And it dawned on me that this virus was really are causing enormous destruction in African American, Hispanic communities, particularly some of the low-income neighborhoods where individuals don't have the ability to work remotely via Skype and Zoom, but are working in family-owned businesses or on construction sites, and they were really getting devastated, I thought. And then we saw the reports coming out of South Texas, and what was interesting about it was you couldn't really go to find one-stop sources to really get a full picture of this situation. You kind of had to find bits and pieces and then string that narrative together. But the message is, I think this virus is causing historic, what I called in the Congressional Hispanic Caucus meeting, historic decimation among the Hispanic communities in our southern states especially. And now I'm worried as this virus goes through our northern states. When I testified to the Congressional Hispanic Caucus, there was a member of the House of Representatives who was Hispanic from Chicago and explaining to me his concerns about the Hispanic community in Chicago, which of course is a very large Hispanic community. And so I'm really worried now about this next phase as we go into the colder months, into October, November, December, and then January. And I think this is something that we still don't have the full story. We also know, which is very interesting from a report out of MMWR and the CDC, that if you look at the deaths among the African American or Hispanic community, 30 to 35% of those deaths are individuals under the age of 65, which is quite different from other populations. So, the bottom line is I think this virus is robbing us of a whole generation of mothers and fathers and brothers and sisters, and mothers and fathers, presumably of teenage kids and maybe kids in their young 20s. And that is every epidemic or pandemic has its unique set of horrors or its own little shop of horrors. And I think that's one of them for this virus. But I still think we need a better accounting and have that full story, because it's me sitting, working remotely, trying to piece together facts and factoids and try to create a narrative out of it. And I know Umair is very committed to this. I know in Houston and Harris County, Umair's boss, the county judge, Lena Hidalgo, is very committed to this, as is Mayor Turner. So hopefully we can get our arms around this a bit more. But I think it's an important narrative that too often doesn't hit the major cable news networks.
Thanks, Peter. And I think that's a wonderful segue. Umair, would you care to weigh in off of Peter's comments there?
Well, first of all, whenever I'm on a panel with Peter, I can just sort of sit back because he says it all, and it makes it a lot easier for me to be on the panel. But Peter, great to see you. I would just echo what he said, and maybe the only additional thing that I would put out there is that we also know from a health equity standpoint that COVID-19 did not start all of the health inequities that we are unfortunately dealing with now in the face of COVID-19. These are long-standing issues, social, structural determinants of health, institutional racism in general, bias, all sorts of factors that come into play. Why are certain communities, suffering from the scourge of chronic conditions in a way that's markedly more so than others? In Harris County, we have the largest disparity on life expectancy of anywhere in Texas within one community, which is about 24 years. And so your zip code is markedly more important to your health than your genetic code, and place matters. And so that really gets to all these other factors that pre-existed COVID, but I will say that COVID has unearthed them in a way that we have not seen almost ever. And this has been a transformational event. And Peter is right. We have folks in our community and beyond, in LA, et cetera, who cannot do virtual meetings, who must go to work, who have to be on the front line to make sure that they get money in their pockets so they can provide for their families. And those are the very people that are then having to put their lives at risk, because guess what? They are having to be out in the community, in public, where they're in interactions with others who may or may not be doing the right things. They may be, but the people around them may not be wearing a mask, or may not be socially or physically distanced, or what have you. And so now you've got a potential for higher risk. And if they also have themselves more likelihood of diabetes or high blood pressure or heart disease or what have you, you may have a situation which unfortunately means you have those complications of adverse conditions and even death. And so I think it's a circle, but ultimately we've got to attack it in a way that really makes sense, because if we're smart about it, which we have not been, by the way, in this country, if we're smart about it, we can take this on in a way that's going to address that. But unfortunately, we still don't have a national strategy, and we still have trickle-down effect that's really impacting all of us in communities across the country.
Well, Dr. Shah, what did you say too? I mean, it's not fixing it for COVID either, right? It's fixing the larger issue, right? Because you can't just deal with COVID. It's taking on the long-standing equity issues that have been there, and the system failures for populations that are disparately impacted.
That's right. Absolutely.
Excellent. Just a friendly reminder to everyone that if you're not speaking, make sure to mute your mics. The mics pick up everything. So now, same question, moving that over to Jorge. So Jorge, how do you think health inequities have played into the pandemic response there in California?
I think it's been well said. Our hospital is in Metro Los Angeles, in the middle of one of the largest Latino communities, and we've all known the influence of these inequities on health and outcomes, and we all known the social determinants of health. But I just want to echo that this has been sort of a shocking revelation to see so many people die. And if you're Latino, if you're Black, you're twice as likely to die and twice as likely to get COVID than if you're white. And so that revelation has been very shocking to many. And I think also the confluence of another event, which is the murder of George Floyd during a pandemic, has really, I think, spurred a lot of reflection in institutions to reflect on why is that? Why do we have these disparities? Why do we have these differences in access of care? Why do we have these different educational systems? And sort of reflect on the role that racism has played in our institutions. And so I think, this has been taken on by the County of Los Angeles as something that I've never seen in my 30-plus year career in LA County, that our system is actually reflecting and looking into this, and our hiring practices, our ability to connect with communities where we work. And so I do think this issue of disparities has been a shocking revelation during this time.
So Jorge, there at the end of your statement, you really started talking about looking forward. So back to the rest of the panel, given all the how we're seeing that the health inequities are playing into the COVID response, being hopeful, thinking about the future, what changes do you hope to see to combat a future pandemic of this size, or even a lesser one? And I wonder if we couldn't first go to Umar and then David.
Well, I think it's hard to really look at the future when we're still, unfortunately, in the middle of it. And I wish that. And by the way, there's just because we're in COVID-19 does not mean that a hurricane cannot happen, or you can't have a wildfire, or you cannot have an earthquake, or you cannot have a terrible other infectious disease and another something. We were watching what was happening in China again recently, and the concern about, is there some other, novel virus that could also make another additional impact on communities across Asia or elsewhere. And, I do think that's the challenge, but I do think there is the question is a fair one, which is, I am so hopeful, and maybe that's optimistic is the right word, but maybe naive is the right word. I am so hopeful that COVID-19 is a transformational moment, not just how we usually do business, which is we get past the emergency and we forget once it's in our rearview mirror about the policy changes or the capacity building or the infrastructure that we need to change or the issues that we need to address, but that we actually do take it on and address those. And so while the future is unknown and uncertain, what is certain is that this will not be the last of a worldwide event, if you will. And if it's not a wake-up call, that's too cliche-ish. I will say that there's another threat that, climate change and climate and health right now is also a threat that continues. And again, it's another example of something that's down the road and it's going to affect, other generations or people, not me. And I don't need to worry about it. And guess what? We're not addressing it. So I do think we have to be very methodical and very, I heard a long time ago this message where we're very good at collecting the dots, but we have to be better at connecting the dots. And I do think that's what leadership is about. Leadership is actually not just about collecting all this information. It's actually about connecting it and making sense of it for people so that when people are actually out making policy decisions by voting, by doing things as members of a society, that they actually have good information that they can understand why we need to invest in systems now, even though the effect may not be for years to come.
Thank you, Amer. With you talking about climate change and the impact of nature, it's too bad that there's not a One Health panel webinar taking place tomorrow. It seems like it'd be a great
on the post-pandemic world. That's right.
So, David, I wonder if we could go to you and talk about what hope would you have? What would you like to see in the future?
So, thank you. Listening to Dr. Shah, we've been talking a lot in public health prior to COVID about equity issues in health, right? And we've been talking a lot about moving upstream. So, stopping trying to deal with the problem in front of us and figure out where did it start and what were the factors that got somebody to where they are and how far upstream can we intervene and make changes that'll create better outcomes down the line. I think we all get that, and I think we all understand it needs to happen. What I don't think we figured out is how to do it. And that lack of a national strategy and national leadership and thought around that, I think, is going to be critical moving forward to help us hopefully, effectively use the wake-up call that I think we've collectively gotten. So I think if we get anything out of this, the ability to be able to really look at our systems, across the board and where we can intervene earlier to create better health outcomes across the board for our communities, so that when we find ourselves in a pandemic again, perhaps we've taken care of some of those things that resulted in these inequities in the first place. And if I had the answer to how we fix that, I'd be very rich, right? We'd know what to do, and we'd be able to push it out to folks. But there are not easy answers there, which I think is part of the challenge, part of the frustration, but also part of the opportunity here to really get creative and think outside of the box.
David, I think the comment about there are no easy answers and no easy solutions there are a good place to end for that question. So I thought we'd go on to some of the questions coming in through the chat box. And what I'm seeing, a number of them related to the chat box are associated
Can I just make one statement to follow on?
You certainly can.
Thank you. So, I have a new book that'll come out at the end of the year. I think it'll come actually in January, to really look at this. And it's called Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science. And I actually started writing it well before COVID-19, because we had started to see an unraveling of all of the great global health programs that began with the new millennium, the Millennium Development Goals and the formation of the Gavi Alliance and PEPFAR and Bill and Melinda Gates Foundation, which made really pretty much uninterrupted gains in global public health for about 15 years. But then starting around 2015, we started to see, this is my premise, a bit of an unraveling. And the unraveling was from things that ordinarily physicians and public health experts often don't think about. Not only climate change, but also war and political collapse, urbanization, deforestation, and this very aggressive vaccine movement, which has now this year become a full-on globalized anti-science movement. And it originally was happening in pockets in places like the Arabian Peninsula and Venezuela and parts of Africa and even in parts of Texas. And then COVID-19 just blew it all up and really amplified all of those forces. So I think one of the messages, how do we prevent the next COVID-19? And there will be. I mean, this is now our third major coronavirus pandemic of the 21st century, meaning SARS in the 2000, MERS in the 2010s, and now COVID-19, and another one will surely follow. Knowing all of these big social determinants of climate change are pushing back disease, how do we address this, and how can we bring in governments and public-private partners? One of the conclusions that I came to in the book was, we always seem to go back to the same players, right? If you look at the funding for global health, it's always the U.S. government, the UK government, and that government called the Bill and Melinda Gates Foundation. And the worry is they're going to get tapped out. And we had the situation now, with the president and the White House pulling out of WHO and the COVAX facility. So it's a reminder that if we rely on any one government, we're setting ourselves up for failure. And the conclusion I came to was we need greater involvement of the G20, including the Chinese, the Japanese, Indonesia, and I think that's still a somewhat untapped source of support for all of this. And actually, when you add up where the world's poverty-related diseases are, not only COVID-19, but also, you name it, leprosy, leishmaniasis, Chagas disease, tuberculosis, dengue, it's overwhelmingly in the G20 nations, the 20 wealthiest economy, but it's the poor living among the wealthy that account for these illnesses. So I think the book concludes that there's been a shift, that the traditional norms of global health, poor countries versus wealthy countries, is giving way to a new normal, and it's still not widely accepted. Just for full disclosure, it's sort of Peter Hotez going out on a limb, and it's by no means widely accepted in global health circles, but the paradigm of poor versus wealthy is more nuanced. It's the poor living among the wealthy that now more and more account for the disease, and I think COVID-19 is going by that flavor.
Wonderful comments, and I hate to go back to you with the very next question, but I think the very next question that's been coming in is probably fairly up your alley, and there are 3 or 4 questions in the chat box all about the vaccines. And to kind of summarize them, one of the summaries here is, with the recent safety pauses to several late-stage vaccine trials, when is a readily available vaccine realistic?
I still think the timelines haven't changed, and there's two big parallel programs in place. We all know about Operation Warp Speed, which is the U.S. public-private partnership, and then there's a big larger global health initiative, which we're part of. So we're now scaling up production of our low-cost COVID-19 vaccine in India in Hyderabad with a large Indian pharmaceutical manufacturer and developer known as Biological E. So we're producing 1 billion doses now. That's really exciting. We've never made a billion of anything before. So that's very exciting. But the U.S. program which is all pharma companies. One of the reasons why we're not included is that there's about 7 or 8 vaccines, and the first 3 or 4 clinical trials, and all 4 involve new technologies never used before for licensing of vaccines. So you have 2 mRNA vaccines from Moderna and Pfizer, 2 adenovirus vector vaccines from AstraZeneca, Oxford, and J&J. The 2 adenovirus vaccines are on pause, and we don't the flaws of rigor is high, the integrity is high, but I think the communications has been poor, and the strategy has been, if you call it that, is to leave it to the pharma CEOs, and they've been fumbling the message quite a bit. So hopefully that will get fixed. But in the meantime, I think we will have data from the 2 mRNA vaccines from Pfizer and Moderna by the end of this year, late November, early December, whether or not they actually work and are safe. And then we should start rolling them out to the public. And we heard yesterday from Dr. Hellerstedt and his colleagues from the Texas DSHS their plan for how they're going to roll it out. And it seems like it's a pretty sound plan. I think one of the obstacles will be that the Pfizer vaccine requires minus 94 degrees Fahrenheit storage, a deep freeze. And so I'm a little concerned how we're going to get that vaccine out to HEB and Kroger and CVS and all the places that adults usually get vaccinated. But we have a 4-star Army general heading the U.S. program, General Gus Perna, and I think they're working day and night with this distributor known as McKesson that did it for the H1N1 flu vaccine in 2009, and I think they will be successful in rolling that out. So by this time next year, I think we'll have multiple vaccines that work and are safe, and so it's a matter of trying to navigate a path for this big surge that's coming this fall and winter, and to get to the other side where we can start getting vaccinated. And then lastly, I'll just say, I'm often asked which vaccine am I waiting for? And the question is, hey, Dr. Hotez, of those 8 Operation Warp Speed vaccine, what are you taking? What are you giving to your family? And what I say is that's the wrong question. Because I don't think we're going to have a lot of choice. It's whatever we can get, given the rationing and the limited supply in the beginning. And I say that's okay, because the thing that I'm worried about for myself and for my family members is I'm really worried about them going through the winter without having in their system, which is how these vaccines work. They're inducing virus neutralizing antibodies, T-cell responses. So any vaccine that's approved, either formally approved or released through emergency use authorization, I will take and recommend for my family, knowing that the best vaccines may come later. Virus neutralizing antibody, it'll prevent you from going to the hospital or being admitted to the ICU. Vaccines roll out, or we learn more information about durability of protection, we can get boosted with some of the other vaccines. Don't be too cerebral about it. You can now get virus neutralizing antibodies in your system, and then and keep yourself out of the hospital through that mechanism.
So thank you for that lovely response. I'll open the question up to the rest of the panel and see if anyone else would like to jump in.
This is the mayor, but what I would just add to what Dr. Hotez just said is I think the concern that we have on the public health agency standpoint is we know that, first of all, there hasn't been a lot of information about how the rollout is going to be occurring. And so we're glad that we're seeing information now from the federal partners, the state partners, to eventually to local partners like us. But the concern is that we still have public health agencies that are also trying to fight the pandemic in the meantime. Field testing, logistics, epidemiology, contact tracing, communications, messaging. Every single simple thing that you can think about is so complicated and complex when you're at it for months and months and months and months, which is what Jorge and David had said earlier. Was just that when you're at it for so long, there is this real fatigue of that system, and that's a real challenge then when there is an expectation for those same public health agencies to be able to provide a safety net, if you will. And so, I do think that's going to be a continued challenge, especially as we get into this continued third wave, and I do believe we're in it. And I'm concerned about what that's going to look like for many of those public health agencies that are out there already doing a lot of activities to fight the pandemic.
Other thoughts from our panelists?
Oh, I would just echo that. And, Dr. Shah, I'm sure you've got staff redirected, right, from many other programs to your COVID response. So I think like Dr. Shah's saying, health departments don't have an army of vaccinators sitting around waiting for the vaccine to come. They don't have that infrastructure has been redeployed to response, right? So, having lived through a number of these efforts over the years, it's certainly nothing on the scale that this is going to be. All of the failings and all of the cracks in our system will be exposed when we try to roll out this vaccine that everybody's going to want. Well, you'll have two sides of the coin. You'll have, when it's out, everybody, the group that's really going to wanting it, the demand there, and then having to counter the other narrative of the doubters and the skeptics and the anti-vaccine folks, and how that messaging plays out in our rollout of the vaccine. But I think you've got that challenge, but I also think you've got the very real infrastructure challenges of communities being able to roll out these vaccine programs in a way that's going to be rapid and effective while they're still in the middle of the response to the pandemic at the same time. I think it's going to create challenges. And I don't think we should expect anything different in vaccine availability and access that we saw in testing and the food fights between all of us to get access to limited testing resources, right? I think we're going to see that play out again in the political side of the house, as well as, within our public health systems, where we're all trying to do right and do best by our communities. But in doing so, when there's limited supply, there are winners and there are losers in that conversation. And I think that's where a national strategy and statewide strategies that everybody has bought into are going to be critical to successful deployment of a vaccine in this country.
So that brings us to a good segue to another question that's been submitted. And just a polite reminder, if you're not speaking, make sure that you mute your mic. The sound picks up a number of things. Remember, with kind of what David was saying there, playing off a little bit about what Umair was saying in regards to the rollout here. What do you think is going to be the one or two most important components of a successful vaccine distribution and rollout? We've stumped the committee.
I'll just say very quickly, I think it's what we talked about. It's communication, especially with, the vaccine hesitancy piece of this, and it's the coordination and real coordination on the public sector and the private sector side, and then coordination across levels, federal, state, local, and community.
And I think if you have shortage of availability, which means you've got to prioritize who gets it, that's going to be a whole other level of challenge and conversation before you even get to the distribution conversation. And I think that will be a tough set of conversations to have, jurisdiction by jurisdiction, community by community, state by state, and could be a real impediment to successful deployment of the vaccine to the highest priority folks, right?
Any additional comments from the panel?
I would just say, we've started thinking about the scenario of having to distribute a vaccine to not only our patients, but also local community. And we've closed off one of our streets, and we've started drive-through COVID testing and vaccination services on our hospital site, in a way of sort of preparing for the need to distribute these vaccines at a level that we've never experienced before.
So, Jorge, I think I'm going to go back to you because this next question that came in seems right up your alley. And they're just talking about with the question essentially with the devastation that the COVID virus has had on the financial stability of many healthcare systems across the country. What are your thoughts regarding hospital survivability or health system survivability across the country? What do you think we're going to see in the coming years in regards to their financial stability?
Wow. I wish I knew that. This pandemic obviously has been devastating financially, and largely because our healthcare system is, I think, reimbursement and profit driven. And I think, I think discussions about changing the whole infrastructure of how healthcare is delivered in this country I would hope that would be an outcome of living through this pandemic. I'm not sure. We certainly our system is depending on CARES funds from the federal government to reimburse a lot of the activities that we've had to do that are non-reimbursable. But I know that's a short-term strategy to kind of keep the health system afloat. I do think that I would hope that something more radical and more revolutionary would happen to our healthcare system.
Just throwing that question out to the remaining three panelists. Anyone else like to weigh in?
From the public health perspective and from the local government perspective, I think we've got an equally challenging situation facing us, right? Because the underpinnings of the financial structures of how governments get their money to operate core services, whether it's police or fire or courts or public health, have also been significantly impacted by the economics of COVID-19. And our public health departments were already struggling pre-pandemic to meet the 21st century public health threats. And when our local governments are trying to figure out how they're going to fund core services, post CARES Act dollars, public health is right there in the mix of services needing local government funding to support the work moving forward. And we will be in competition with all of the other government service provider stakeholders to try and get access to limited resources for ongoing support of local public health. So I think we've got some real economic challenges ahead, just in terms of the financing of not only our healthcare delivery system, but our public health delivery system as well.
Yeah, I agree with both what Jorge and David have said. I also think that again, as we talked about earlier, it's a watershed moment. It's a strategic opportunity for us as a nation to get it right. And, getting it right is difficult when, one, you're still in the midst of the pandemic, and that's going to be going on for who knows how long. And number two is that we've seen a fracturing of the political nature of this, the fracturing of our nation, and people have picked sides undoubtedly, regardless of what really is. Regardless of what science or evidence or health or medical or public health say, it's a side that's been chosen. And then you put all of that in the midst of a society that has been transformed. It's going through transformation. And then you bring in the funding woes that are really going to be challenges throughout. And that's just it's a recipe for an opportunity, but it's also a recipe for, if not done well, again, with strategy and leadership, it could potentially be a second disaster on top of what we've already seen with COVID-19 itself.
Yeah, I'll just add, what we're seeing now, both out of the White House and even beyond the White House, is a pretty aggressive anti-science disinformation campaign around false, fake ideas around herd immunity that occurs around 20%, or trying to discredit masks. And there's a source that it comes from. There has been an anti-vaccine movement around since the late 1990s with the publication of the fake Wakefield paper. But then, I've been writing a lot about this because I have a daughter with autism and wrote this book called Vaccines Did Not Cause Rachel's Autism. But what happened around 2014, 2015, and really revved up with the 2016 presidential election, it took this curious pivot to political extremism under this banner called health freedom or medical freedom. And this is when political action committees were formed, organizations like Texans for Vaccine Choice, Oklahomans for Vaccine Choice, and it drove up vaccine exemptions in many states, including Texas. And then there were also national organizations were created, like RFK Jr. created Children's Health Defense and others. And this created a huge amount of problems, and they began dominating the internet with fake anti-vaccine messages. And Amazon now is a full-on anti-vaccine website if you go to the vaccination books. The issue that happened with COVID was I thought that when COVID-19 emerged and people were clamoring for a vaccine, this would have been a time when the anti-vaccine movement might go into hiding or retreat, or at least, not be so dominant. And what they did was they used this opportunity to expand their remit to not only use health freedom to campaign against vaccines, but masks and contact tracing and social distancing. And it's a major reason why we have so many people who've perished in COVID-19, because, now not wearing masks is tied to this bizarre form of political allegiance, which doesn't make any sense, but that's what's happening. And now what we're seeing is leaders of the anti-vaccine movement have now exported this. There's been protests in Trafalgar Square in London, in Berlin, and in Berlin and these other places in Paris. It's been now linked to QAnon, and CBS News has reported, and others reported that it's been linked to neo-Nazi groups. So it's taken this very ominous twist and turn, and it's very formidable. I don't know where they get their funding from, but it's become this full-on anti-science movement, and we're going to have to figure out how to address it, because it is causing a lot of damage. And I think most health organizations in the federal government always had the attitude, look, we're not going to call attention to this because it'll just give it oxygen. It's got all the oxygen that it needs. It's now ripping through many states in this country and now into Europe. And I think this is going to be a big challenge for us, how to address this and what the best approach might be. And because of that, now RFK Jr. has now labeled me the original gangster villain, the OG villain. So on his Instagram site. So I'm going for me. So you've invited the OG villain.
I was going to say that's by far a cooler nickname than I've ever had. So with that, we've got time for one more question for the panel. So I thought we'd just go around the question and just your final thoughts. what would you like to share with the group here? What are your final thoughts in regards to the response, and what are the takeaways that you'd like to leave everyone with? So I thought we'd end with David Solilis out there in California.
Sure. Well, I think, thank you for hosting this conversation tonight. I've really enjoyed it. And for our colleagues that are on the line and participating, you're all on the front lines too. And want to just thank everybody for their effort and their support and the roles that people have played throughout this response. For me, I think, I hear a lot about people saying, I want to just go back to normal. When is it going to be normal again? And I think, that plays into the whole challenge of the COVID fatigue that I think people are experiencing too. And, we're really trying to figure out how to, help people understand that these are not normal times. These are extraordinary times. And these extraordinary times call on all of us to step up in a different way than we normally would have, not just for our own personal health, but the health of our communities. And I think we all just need to keep echoing that and need to keep supporting each other and our workforces and our communities and being able to be all in on the response moving forward. So thanks again for the opportunity to be here tonight. I've really enjoyed it.
Thank you, David. Greatly appreciate that. Remember, if you're not speaking, make sure to mute your mic. Next up, I thought we'd go from California to Texas. Dr. Shaw.
Let me echo what David just said in terms of gratitude, Sean, to you and to fellow panelists, and a very, very important discussion. And I would really, I'm glad that Peter joined and was able to join to give the insight on the vaccine piece, because that is the biggest concern that we have is how do we, I don't know if it's the right way, but how do we get out? What's our exit strategy? How do we get out of this conundrum of where we are? And we talk about the 3 W's of wear your mask, wash your hands, watch your distance. I added the 4th W of will. It's the political collective will, and it's the individual will to actually not get tired and fatigued and forget that we're still in this pandemic, and that we have to all be, as David said, all in, and all in to win. I mean, it's really what we're trying to do. Maybe that's a 5th W there, but it's really about, at the end of the day, how do we really make sure that the road ahead, while we're all fatigued and tired and just ready to roll from this, we have to remember that we are nowhere out of this. And flu season, obviously election season, flu season, 3rd wave, and what's coming post are concerns to all of us. And in the midst of all this, we still have an opportunity with vaccines, which hopefully vaccines will allow us to protect people beyond just the everyday things that we've been saying, although those everyday things are going to absolutely still need to be in place. And so I do think what really is the most critical piece of this is thank you to all of you as our healthcare executives to work and be willing to really lead your teams and work with us in healthcare and public health and beyond. All of us are in this together, and we have to remember that if we work together, we can fight this pandemic successfully in this country. Unfortunately, to date, we haven't worked together as a nation, and I'm hopeful that changes once we get past this election, but let's see.
Thank you. And from Texas back to California, Jorge Orozco.
First off, really an honor and pleasure to be on this panel with these illustrious panel members. Although we focused on many of the challenges during COVID, I do think there are a lot of good things that are coming out of this. Our primary care clinics went from probably 12% telephone visits up to 90% telephone visits during this pandemic. And it's really taught us that, our patients don't need to take 2 or 3 buses to get to the hospital and to receive all their care. There's certainly a number of patients that need to be seen in person, but a lot of the care can be delivered via alternate mechanisms. And so we've certainly learned that, and I don't really see that ever going back to the way it was. We've also, implemented home oxygen programs with remote monitoring. And, these are patients who come into our emergency room that typically would be admitted because their oxygen saturation levels are low. But now we're able to care for them safely at home. A lot of our employees are teleworking. We finally have solved our parking problems here on our campus. So, we've learned a lot of lessons and that have been good for us. And I just want to also share that side of things. And I want to just also share with my colleagues from Houston and Texas that the Dodgers are currently playing, and right after this, we're going to go watch the Dodgers win another championship. So.
Well, good luck to you there with the championship. And now from California back to Texas, Dr. Hotez.
I am not going to comment about Major League Baseball tonight. Out of respect for my hosts, I will hold back. Since he's not back there. What I wanted to end with is, as I said when I first came on, and I apologize for being late. Things will be better. We'll be in a much better position next year. But even when we have vaccines available, remember, many of these vaccines may be only partially protective. Some of the experimental studies show that the vaccines seem to greatly reduce severity of illness in non-human primates, but a lot of the non-human primates often still shed virus in their upper airway with some of these vaccines. So that means that even after vaccines are out, there may be companion technologies to continuing the mass and the contact tracing. It's not going to be, like the Salk vaccine where we learn about the result and everyone goes dancing in the streets. It's going to be an evolving process of improved vaccines. And so we're still going to need the Umair Shahs of the world to tell us how to integrate vaccines as part of a larger strategy. I think that's point one. Then the other is the fact that as those vaccines become available, we still have to get through this horrible winter. And most of the predictions indicate it's going to be pretty rough, maybe worse in the northern states. And in Texas, maybe worse up in the Panhandle of Dallas, although El Paso is pretty horrible too right now. So, and look after your mental health during this period. Figure out try not to be alone if you don't have to. Let's identify a small group to social distance with, whether it's a couple of family members and friends. Try not to break that social distancing too much, and have access to mental health counseling. You're going to get depressed and sad and scared. It's a normal reaction to a stressful situation. Have numbers of mental health counselors available for you or your friends or your family. It's going to be a tough time. It will get better, but it's going to be a tough time.
I think that's a wonderful note to end our Q&A session on. Really make sure that you're taking care of your own personal well-being. And now's a great time to reach out via phone, Zoom, WebEx, etc., and check on those loved ones and friends you haven't had a chance to touch base with in a while. So before I turn it back over to Mark and Tom, I would just like to thank the Texas and California chapters of the American College of Healthcare Executives for hosting this panel. I would like to thank our panelists, David Solilis, Jorge Orozco, Umar Shah, and Peter Hotez. Thank you all for your time this evening. And then I'll turn it over to Mark and Tom to talk about the networking event.
All right. Thank you. This has been enrapturing. I said in the chat I could go at least another couple hours talking about this stuff. We have the slide, I think, up for the Zoom link. I know that we sent that out to all of the participants in Houston that had signed up for the networking session. So go ahead and click that. Once you do, you should be assigned to your networking room. And we have moderators assigned to